Thanks to the organizers for giving me this opportunity to present some of our work on neuropathy and neuropathic pain. Very quickly, I'm going to go through some definitions of those two phenomena, how we diagnose them, briefly review historical aspects and what has evolved over time with changes in antiretroviral therapy, briefly go over the pathogenesis of neuropathy, talk about the current burden and clinical impact of the condition and the contribution of the brain to processing pain, and finally, how we manage pain and the potential for neuroregenerative treatment to improve peripheral nerve function. So, we diagnose peripheral neuropathy as a set of findings on examination. This consists of symmetrical, distal, more than proximal involvement of sensory function with reductions in sharp, temperature, vibratory sensation, and position sensation. Sensory is typically involved to a much greater extent than motor, and there is typically loss of distal reflexes, particularly the ankle jerk. What patients pay attention to is the symptoms rather than the signs of neuropathy. So when they come to clinical attention, it's mostly because they have burning or stabbing pain. They report pain from normally non-painful stimuli. Some things as simple as the bed covers touching the feet are very uncomfortable. They can also report distal numbness and paresthesias, which are less bothersome, and rarely mild distal weakness. And what you see in that histogram is that 40% of patients with the findings of neuropathy on examination don't report any symptoms. And we know this from research studies where we systematically ask them about symptoms. So you see in the Venn diagram some, but not complete overlap between the presence of symptoms and the exam findings. Stimulated skin wrinkling is an interesting potential diagnostic abnormality, which I will just briefly mention because it's kind of an interesting phenomenon. So all of you are familiar with the fact that when you spend a lot of time in the water, you'll start to see some skin wrinkling, which is displayed here on the left-hand side. And that is actually an active phenomenon, not just a passive waterlogging of the skin. And it has to do with activation of sympathetic small fibers in the skin that retract some of the connective tissue. We also use skin biopsies to characterize epidermal nerve fiber density. You can see in the lower panel here, in a normal skin biopsy, using PGP 9.5, we visualize clearly very distal ends of small nerve fibers, unmyelinated, extending up into the dermis and epidermis. And in the context of neuropathy, the fibers are lost, and there are these abnormal excrescences where the fibers end in bulges rather than free nerve endings. Of the 1.1 million people in the US with HIV, about over 600,000 are estimated, projecting from our research findings, to have findings of sensory neuropathy. And of those, about 100,000 have moderate to severe neuropathic pain. People with distal sensory polyneuropathy In the pre-CART era, so before combination antiretroviral therapy, the risk factors were increasing age, current use of antiretroviral therapy, past use of D drugs, and a lower CD4 nadir and a history of opioid abuse and dependence. And I'll come back to this later because that picture has changed quite a bit. Having neuropathic pain is associated with a very significant reduction in quality of life, both physical and mental health, and also with a variety of other complications, including major depressive disorder, lack of employment, and becoming dependent in activities of daily living. The neuropathogenesis involves two major changes. One is infiltration of activated macrophages into the dorsal root ganglia where the sensory neurons live. And the second is abnormal mitochondria and mitochondrial function that we believe to be induced both by HIV proteins such as TAT and also by antiretroviral therapy, and much more likely with the older drugs that are no longer used. We've come to realize that distal nerves are not static structures, they're highly dynamic. They're influenced by a variety of trophic and toxic factors, and the balance between these two is what determines the configuration of the sensory neuron and its fibers. The major evolutions in the treatment and disease landscape in HIV are the availability of these new antiretroviral regimens that are more potent, more convenient, more tolerable, and have markedly reduced neurotoxic potential. At the same time, the burden of diabetes and other metabolic conditions that represent risk factors for neuropathy has increased. So we've got these two countervailing forces. And so we did a study to look at the evolution of distal sensory polyneuropathy and distal neuropathic pain over 2 years and identify risk factors for new onset or worsening of these conditions. Cutting to the bottom line, over 250 individuals followed for 12 years. 50% of them virally suppressed. We saw neuropathy prevalence increase from 26% to 44%. Incident, so new onset DNP, neuropathic pain occurred in 42 of those who didn't have it at baseline, and of those who did have it at baseline, 29% worsened. On the left here, you can see the risk factors for incident neuropathy signs. I'll look at symptoms in a moment, but the main ones are older age, increased height, which we've known for quite a long time now. Taller people are more likely to show DSP signs on exam. And then the presence of distal neuropathic pain is also a risk factor for incident neuropathy. On the left-hand side, the risk factors for neuropathic pain, advancing age, higher body mass index, so obesity is a risk factor for worsening neuropathic pain, and not being employed is another risk factor. So employment actually is protective. People with neuropathic pain have a markedly reduced quality of life, as we mentioned previously. So that association has continued. And so in conclusion, even though we have better antiretrovirals that are less toxic, we continue to see an increase in these neuropathy conditions. However, it's important to remember that many older people with HIV remain free of these conditions. And we'd really like to know what are the factors associated with absence of these conditions, because this may give us a clue as to potential treatment abnormalities. Notably, the factors that have been associated with incident pain and neuropathy are quite different from the early CART eras. So previously, exposure to D drugs, CD4 nadir, and viral suppression, none of those things is any longer a significant predictor. And now it looks like body mass index, obesity is a predictor, and employment was protective. We think that it may be a surrogate for unmeasured health factors such as socioeconomics and regular exercise. So given these developments, it's time to re-examine how we treat this condition. And at the end, I'll talk about a couple of novel therapeutic approaches. One more important reality of the clinical impact of neuropathy is this marked increase in fall risk or balance disturbances. As you know, falls are a major source of morbidity in people with HIV and in the general population. And although neuropathy does not seem to be noticeably predictive of balance problems in the non-HIV population, in people with HIV, it's a highly significant risk factor. And this is based on a study of almost 3,400 participants. The brain has a major impact on the clinical phenotype of neuropathic pain. This is largely, the substrate is the dopaminergic projections, particularly the mesolimbic projections and mesocortical projections that innervate the cortex and structures like the nucleus accumbens projecting from the midbrain. This dopaminergic system has been studied in great detail in normal individuals. And what we found is that a genetic variant strongly predicts or associates with pain perception. So a common variant in the catechol O-methyltransferase gene, which this variant is associated with reduced enzymatic activity, leading to higher synaptic dopamine levels. And these people have much greater pain perception, lower pain thresholds. And this can be indexed by opioid activity in the nucleus accumbens, which is regulated by dopaminergic system. We looked at this same COMT variant in our people with neuropathic pain. So we hypothesized that this would be a moderator of the relationship between signs of neuropathy on exam and the clinical phenotype of neuropathic pain. And in over 1,000 participants, as you can see in this multivariable analysis, the MET variant was associated with a markedly increased risk of having neuropathic pain. So this variant affects the clinical phenotype. Another source of the central nervous system modification of pain processing is the default mode network, which is a network of brain structures that in which activity is temporally linked. These structures including the medial prefrontal cortex, the cingulate gyrus, and the inferior parietal cortex. So when a person is essentially daydreaming, this system becomes active. My colleague John Keltner has done studies in which he showed that individuals who experienced neuropathic pain had smaller posterior cingulate cortex, the posterior cingulate being one of the components of this default mode network. And preliminary data from functional MRIs also show that blood flow changes are associated with pain expectation in people who have neuropathic pain. The overall interpretation of all these data is that this mind-wandering default mode network is a mechanism actually to distract the brain, if you will, from painful stimuli. And the characteristic of people who experience pain is that they have a reduced activation in this network. Just a few words about treatment. We are highly motivated to seek alternative effective treatments for the neuropathic pain, because we now have this as a lifelong disease, as you saw, contributes to polypharmacy, often incomplete response to analgesics, even opioid medications, and other adjunctive neuropathic drugs. These are some of the drugs that we use. They are moderately effective, but as I mentioned, there are many treatment resistant individuals. One of the less well-known interventions is this high-dosed capsaicin, which is must be administered in a doctor's office with pre-treatment with opioids, because it's a very painful treatment, but a single treatment results in a marked reduction of those epidermal nerve fibers that I showed you earlier, and typically up to 3 months of pain relief from just a single application. So a very, very interesting and promising new pain intervention strategy. Another intervention that we are spending a lot of time focusing on is the endocannabinoid system, which can be manipulated using exogenous cannabinoids like cannabidiol and THC. The receptors for these endocannabinoids are highly represented in brain structures that are important for pain perception. And a large number of studies have shown significant benefit in terms of neuropathic pain on administration of cannabis. These are principally very short-term studies because historically it's been these required inpatient treatment because of restrictions, legal restrictions. We were unable to send people home with the drug. But at least in short term, it shows considerable efficacy, and long term, lots of anecdotal evidence. Finally, I'll mention one of the novel pathophysiological insights. So I told you that there are a variety of trophic and toxic factors that influence the balance between sensory neuronal health and degeneration. And it recently was discovered that an M1 antagonists enhance neurite outgrowth. So in other words, neurons are constitutively under the influence, a negative influence of muscarinic receptors on their neurite outgrowth. And by blocking those receptors, you can enhance neurite outgrowth. And diabetic neuropathy has been studied looking at the intraepidermal nerve fiber density that I showed you earlier on skin biopsy. And these topical antagonists have been shown to be effective in restoring nerve fiber density and have very little systemic side effects because they're administered topically. So that ends my presentation. I thank you very much for your attention and hope this was interesting.